I'll kick off. Welcome everybody to September Health in Hackney. I've had apologies from Councillor Patrick and Councillor Goldberg. We are joined in the chamber tonight by Cllr Adams, Cllr Oguzkanli, Cllr Turbot-Deloff, and Dr. A.D. Cooper, who's the independent chair of the Adult Safeguarding Board. This is a hybrid meeting. It's being recorded. Members of the press may be watching. Please keep your microphones on mute. Please don't use the chat function. Please raise your hand if you want to speak. I haven't been notified of any urgent items. Declarations of interest. I've had one from Councillor Samatar, who I'm told I can't say it. I'm told, Councillor Samatar, I'm told you have to say it. So can you please declare your interest?
Thank you, Chair. Good evening, everybody. I am a wellbeing network coordinator for Mind in the City Hackney.
Just to be clear, item 3, substantive item 3 on the agenda is the recommissioning for the mental health network, the contract currently held by Mind, and I understand Mind will be rebidding for it. So hence that. Are there any more declarations of interest? I don't believe I've been notified of any. No, thank you. So with that then, can we go straight into item number 4, which is the Safeguarding Adults Board. We're joined by Dr. A.D. Cooper here. We've got Georgina Diba, who's the Director of Adult Social Care, and Helen Woodland, who's the Group Director. Dr. Cooper, we've got several new members of the Commission because we're in a new administration. So could I just ask, maybe before you do the report itself, could you just give a 2-minute overview about what the role of the board is, what it does, as almost like a 2-minute, 3-minute training session, just to bring everyone up to speed? Over to you.
The lights come on, so it's working. Good evening, everyone. Thank you for inviting me to present our annual report to you. So I'm the independent chair of the City and Hackney Safeguarding Adult Board. Safeguarding Adult Boards exist for every local authority footprint in England, and they're partnerships, strategic partnerships, who are responsible for safeguarding vulnerable residents in a geographical area. The CARE Act gave a number of duties and responsibilities to Safeguarding Adult Boards, and there are 3 key ones, of which delivering and publishing an annual report is one of them. So today, this evening's event is part of our statutory responsibility. So the partners, the key statutory partners are the local authority, health services and the police, but the partnership is a much broader partnership with a number of members, as you can see from the annual report. And also we're a bit unusual in that we cover the city and Hackney, so we cover 2 geographical areas. We have to have a strategic plan, and in fact we have a 3-year strategy, a 5-year strategy, which was revised last year. And then each year we produce an annual strategic plan, which says what are the priorities that in Hackney and City we are going to focus on during that year in terms of ongoing development and improvement in safeguarding work for vulnerable residents, but also in responding to the challenges in terms of safeguarding, because it changes over time. And so we look to the data and intelligence locally to identify the local priorities that we might want to address through the subgroups and the infrastructure of the board. So the annual report gives you a flavour of that. It gives you a description of what the multi-agency partnerships deliver, but it's the sum of its parts. So it also has contributions from each partner on what they've been doing during the year. And the purpose of the board is to ensure that agencies meet their own statutory responsibilities around safeguarding adults and also work together in partnership to achieve improvement overall and development overall. So is that okay by way of background and introduction? But I'm happy to take any questions about how the board works. I've been chairing the board now, I think, for 7 years, and I'm actually a Hackney resident, so I'm very pleased to be able to, after years and years working in local authority social services, be able to do something more local. So what you have today, this evening, is the annual report for last year. It gives the sort of summary of what we've been achieving during that year, and obviously it was quite a challenging year with COVID, and it was very important that as a board we monitored what might be the potential and actual impact of COVID in terms of safeguarding issues in City and Hackney. But in addition, there were a number of sort of key achievements and areas of improvement, I think, that we were able to demonstrate. One of the 3 responsibilities we have is undertaking safeguarding adult reviews. And although we didn't have one during the year, we looked at how well practice in the improvement was embedded from a safeguarding review that was quite public, of a gentleman, Mr. MS, who died in Stoke Newington. He was a homeless person, and what we had during last year was an event where we came back to look at whether the things that had been recommended to be put in place following that review had actually achieved any changes in practice. So the original reviewer came back and talked to practitioners, the independent reviewer, and he was able to say, yes, things had changed in the right direction in response to those recommendations. We have responsibilities for commissioning training, and we were able to online continue to deliver training, including trauma-informed training, and also during Safeguarding Adults Week in November, a programme of virtual events which helps to improve people's knowledge and understanding of local safeguarding issues. There was a case file audit, which is helpful because it looks at the detail of what's going on in particular cases, to see whether there's learning for the plan that comes out of that. And it's interesting to note that it was on self-neglect, which is one of the 10 different areas of safeguarding that the guidance identifies. And self-neglect this year has been the most significant increased form of abuse, and we think that's tied up with the impact of COVID on local population.
Repeat that again. Which has been the most?
Self-neglect. So people who self-neglect, and that's reflected to some extent nationally as well. I don't think we're an outlier, but it is significant. So the data for Hackney has been tricky, as I'm sure you'd appreciate. And the previous year, because of the cyber attack, we didn't have data on safeguarding activity, but there is a full data set for 2021. I do advise it's read with some caution, and not too much is sort of judged from the data, because we know that it was an interim system and it may not have been as accurate as one would want. However, there was an increase in the number of safeguarding concerns that were raised, and there was an increase in the number of safeguarding inquiries that were made. And as I said, self-neglect was the fastest growing form of abuse. And therefore, it's not surprising that abuse was most likely to happen in someone's own home by someone known to them, given that in Hackney we don't have many residential nursing care homes, which is the other location, one of the other major locations for abuse and neglect. What's very helpful and pleasing for me as a board independent chair was to see that the vast majority of people were asked about what they wanted to achieve through the safeguarding processes, and that the majority of those were mainly or partially or fully achieved. And that's a really good indicator of practice, because what we're looking to make sure through a program called Making Safeguarding Personal is that people are involved and engaged in these processes so they can keep themselves as safe as possible, not just during the time of inquiry, but also longer term in terms of their management of the risks or issues in their lives that are causing them harm or abuse. The other things that I would draw attention to, we don't just work in isolation as a Safeguarding Adults Board, we work with other boards and partnerships in Hackney, and we have had a piece of work going on for some time with colleagues from the Community Safety Partnership looking at antisocial behaviour and safeguarding, and we've been able to look at the different pathways and protocols and panels that meet, that support and help people in those areas, and I'm hoping that that will have some impact in terms of the knowledge and understanding of management of situations where antisocial behaviour is a factor and a feature. We've also been working with the Community Safety Partnership and Children's Partnership on transitional safeguarding, and the other areas of work. Think family is an emerging area of work that we're planning to prioritise during this year. We had an intergenerational domestic abuse policy published, and that's about helping people where they're being abused by family members of carers, and so it's about adult children or relatives abusing their parents or grandparents. And I have to say, this was an issue that seemed to be exacerbated during COVID, and so I'm very pleased that we've got the tool that then helps practitioners think and work with families in those circumstances. You know, that's one of our purposes really, is to support the frontline staff in whatever way we can to work and improve how they work with residents in the borough. I've already mentioned that there was very good work through the COVID period, particularly around testing and vaccination, where there were maybe issues with people's ability to consent to vaccination and testing. And our Hackney CVS partners continue to raise issues around race equality, and we were able, in the context of the Cllr Q work, adopt a similar approach in terms of safeguarding adults to our colleagues in the Children's Partnership, which I think is really important, that there's a consistency of approach. However, I'd say that despite some really good work that was done, there were some things we weren't able to do, and I am of the position that it's better to be ambitious and not achieve everything than to not be ambitious and be complacent with what you can achieve. So we have not been able to continue the work that we had pre-COVID in engaging with residents, and that's partly because of the COVID lockdowns. It is quite tricky anyway, and it continues to be challenging to engage with people who are residents or service users in Hackney in the work that we do. But we are using, we've just commissioned an advocacy organisation to get feedback from residents, and hopefully that will help in terms of that area of work. We'd also hope that there would be some work reported to the board in terms of preparing for the forthcoming Care Quality Commission inspection process, because one of the 4 domains is safety and safeguarding, and that has been delayed. We still haven't seen the methodology for those inspections, so it's a bit tricky to be able to do that work until you see more clearly and concretely what CQC, the Care Quality Commission, is planning. We've recognised the ongoing impact of the economic crisis in terms of fuel and food poverty and the cost of living impact, and had some really helpful presentations from colleagues and included that in our strategic priorities for this year. I'm extremely concerned, and as are the board members, around what will be happening through the winter period in terms of safeguarding risks and issues. We are also aware that there are some safeguarding adult reviews that were being developed during last year that are will be published during this year, and we'll need to be doing some work with staff across agencies around how we take forward the learning from those safeguarding adult reviews. Thank you. I'm happy to give more detail. Or
no, that was very helpful. Lots of areas, I think, thought-provoking there. I just out of my own interest, I'd like to, just before I throw it open to other members. So in terms of, I hadn't thought about it in terms of what you just said there, in terms of the cost of living crisis and the risk there, of course, yes. presumably what you're talking about is the risk of people not being able to afford to put on heating, and how what our role is on trying to foreshadow that and provide assistance. So what sort of thinking is possibly going on as to what the council's role in a safeguarding capacity is there?
So in terms of the partnership, where this has come, one of the areas that we're looking at, which the council colleagues have been engaged with, is around fire risk. We've actually had 2 fire deaths over the last few years in Hackney, and a safeguarding review, 2 safeguarding adults reviews looking at fire deaths, because fire risks for people who are have care and support needs. It's an area of safeguarding risk. The fire brigade members of the board are also extremely concerned about fire risks in terms of inappropriate use of candles and heating as we move into the winter. So we've worked with colleagues at some basic sort of awareness around fire safety that should be launched in the next few weeks, hopefully, that partners in the board can then share with through their staffing networks to try and raise awareness around safer, or sort of mitigating some of the risks around fire safety. So that's one area that's already come up. In terms of other areas of potential risk, again, I think what we're looking to do is not duplicate, but publicise and promote initiatives that partners are already engaged with, so ensuring that all partners of the board are aware of the council's initiatives around addressing the cost of living crisis where we can. So I think it's an ongoing, what shall I say, it's an emerging agenda, but as partners of the board bring issues, but also their initiatives, we can see how we can add value through the board and through the partnership to ensure that as many people as possible in the borough are aware of what help there is that can be afforded.
Councillor Oguzkanli.
Follow-on question from that, and I wonder if you could concentrate on the mental health aspect of cost of living crisis, and whether you anticipate any increase in need for service users, a number of service users as a result of cost of living crisis, and whether council, local authorities and the partners are equipped to deal with that, and what kind of further challenges anticipated, and what kind of resources are in place to deal with those challenges.
I think it's a very pertinent question. I think there are a whole range of ways in which this crisis is impacting on people's lives, and certainly the emotional and mental distress elements are really key. I think for the Safeguarding Partnership Board, what's critical is what are those safeguarding impacts in terms of, for example, the increase in self-neglect as people are unable to look after themselves. And as I said, we've already seen an increase. I know Georgina's on the call and she might want to comment about the sort of increased focus on how the social work services are responding to self-neglect. Obviously, we have mental health trust partners on the board, and I'm just trying to think whether they haven't said anything specifically directly recently in this context, but we have got a board meeting coming up in October where we'll continue this conversation with partners around that. So I'm happy to raise that as a specific challenge and issue. But it's more than just the mental health trust. It's, I think, more broader mental health and ill health and distress issues. My concern as the chair of the board is that we see the risks increasing in terms of safeguarding, not just in terms of self-neglect, but in terms of abuse as people are unable to cope. What we do know is that, for example, carers' stress can lead to abuse because of the psychological distress that they're under. So it's how it might impact and how that then might come through in terms of what staff are seeing with the people that they're working with. But I wondered if Georgina wanted to come in on that point.
Thanks so much, Adi. So I think 2 points I would raise. I think the first in terms specifically around mental health. I feel quite assured actually just looking at the services which are on offer, not just the kind of primary services around GPs and secondary services, but a really strong community and voluntary sector that we have in Hackney. The Wellbeing Network, for example, so very much about trying to support individuals as we come to identify that they are worried or stressed about kind of cost of living. So it's very much about linking in that mental health support while also making sure we're giving them the practical advice. And I think what the council does have is a kind of a range of information and practical tools that we're sharing with mental health colleagues so that we're all kind of linking together and trying to support people the first time they come into contact. The second point that Adi mentioned around potentially increases around self-neglect, absolutely, I think that's an area we'll keep kind of strong oversight of and supporting our workforce to identify where self-neglect is linked to cost of living, and again, how we can support our residents to access what they're entitled to, but equally that risk of intergenerational domestic abuse. And again, supporting people to look at how we can support carers who might be under additional pressure or stress, or equally supporting those who may be perpetrating abuse but might need an alternative response in terms of, for example, we've got adult children who might be seeking financial support from their parents and who don't feel equipped to say no or experiencing abuse. So again, very much working in partnership to address those types of cases.
It's very helpful, thank you. I saw next Cllr Baffour, and then I've got Cllr Turbot-Deloff. Can I just very, very quickly, I mean, as I understand it, the council will have a discretionary fund to assist people in certain circumstances. I mean, on previous times it's come to us, that's not always used up, and it's quite frustrating when we know there's a high level of need, particularly entering the cost of living, and that's not being used. I mean, to what extent are you cascading out amongst the workforce to maybe apply that laterally for maybe the situation where you've got younger people possibly because parents are impacted in a cost of living situation, and that could give rise to the abuse, to think laterally about that, about how you can use that as a mitigating tool?
So I think absolutely. I think it was on last Friday that a booklet was circulated, quite a big booklet actually, with a range of all the different funds and grants that we can help. Not only was that cascaded to staff as a news flash, but was sent to, for example, all our health partners. We've ordered copies for our GP surgeries, for hospitals, for people on discharge, including those who might not actually meet statutory care and support needs. So, as I think Adi's mentioned, the partnership is often about cascading information and making sure all partners are aware of what's on offer.
Thank you. Cllr Baffour.
Yeah, I think my point was more related to Georgina's second point about reaching out to self-neglect kind of community group. And my concern mostly will be more like Hackney is more diverse community. In terms of languages, most of them, their second language. So how you tailor kind of activities to reach them to ensure that they understand and know whatever so that they can be engaged.
So, I mean, I guess for me, safeguarding, and we say this, we hear this all the time, is everyone's responsibility. And I think the reason we say that is that we do depend on our partners. We depend on our members. We depend on those who are out in the community to often be the voice for adult social care or for some of the messages coming through the Safeguarding Adults Board. And interestingly, when we look at the data around who is referring in reports around self-neglect, it is often the community groups, it's neighbours, it's actually people in the community who are noticing concern about someone who might appear to not be self-caring, or they're noticing, for example, hoarding or disrepair. So we are, very much about working in partnership with everyone and making it easy to report in. And I think for me, it's about making sure people know where to report and making it simple as an email or a phone call, or any way that people kind of choose to contact. If there is a concern, that they know that it will be responded to. I think that's the most important message. In terms of language and communication across adult social care, we work with people who may lack capacity, who don't have English as a first language, who might have a learning disability. So that's, I think, just part of the skill set that we expect our practitioners to have. So just to be assured, if a concern does come in, we've got a range of tools, skill sets, ability to communicate with people based on their needs.
Thank you. Cllr Turbet-Deloff.
Thank you, Chair. Good evening, everyone. Thank you. This has been a really good report to read, and also to hear how you have explained part of the achievements that's happening last year. I have just a little bit of a two-part question. First is, would it be possible, perhaps at the next report, to have some figures or data or numbers of all of the achievement that you mentioned? It's a bit perhaps following up on mental health cases. We're very aware that there is a waiting list happening. I'm not sure this is the right place for it, but it'd be really good to see across when it comes to safeguarding, there is a point where mental health support is identified as a need within that safeguarding of adults. And the second bit is, it's just really good news to hear on achievement number 5 on antisocial behavior. It's really good news. It sounds like a really exciting board. I wonder if it's possible as well, or if it already exists, that at some point when a young person or anyone, but specifically I was thinking of young people, where the antisocial behavior has a corner point where it's identified as actually a mental health need and not an antisocial behavior. And then that pathway leads to support initially with mental health for a young person or young adult, or vulnerable adult. Thank you.
If I start and then other colleagues can join in. So I think the issue on data on cases in terms of people with mental health needs, the data we present is the data that's reported nationally, so it's against national frameworks as opposed to local. We don't have any flexibility. This is the data set that we have to provide. In terms of identifying who might have mental health needs, I need to look to Georgina to see if that's possible to pull out, but it might be quite tricky. What we can look at is whether things like psychological abuse or self-neglect are the types of abuse, because that's the way in which the data is collected. Okay, but maybe colleagues might be able to help on that. Around the second issue on antisocial behaviour, I think this piece of work came about very specifically because of that interface between is the antisocial behaviour a manifestation of mental health distress, and how situations were being approached, and were they being approached in the best possible way, and were people's needs being looked at by multi-agency forums that were most appropriate to try and support them to improve the situation they're in. So I do take your point about pathways and mental health needs and the appropriateness, and that was very much the kind of underlying driver for the work. What hopefully we've done, and what I'm hoping to do, is we agreed we wouldn't meet for a period of time, I think it's 9 months or a year, and we would come back and review whether the work that had been done has had any impact. Because it's all very well putting stuff out and saying this is improving people's knowledge and understanding of how things work. But what you want to do is have behaviour change, so actually things improve and they do it differently. So in that piece of work, hopefully we'll be able to come back and say what we've seen is a difference in X, Y, and Z that actually demonstrates that the ambitions of that piece of work have been achieved. If that's helpful. I don't know if anyone else wants to come in around mental health.
Georgina, I've got quite a few. Georgina, just want to quickly say, is it possible to pull the data, mental health data?
It is. I was quickly trying to do some calculations on my screen here. We can provide data next year around primary service user type, so LD, mental health, older people, etc. And I think for this year, I believe it's approximately a quarter related to adults whose primary need was mental health. I say that because someone could have a mental health and a physical disability, or a mental health and a learning disability. But we do report, and we can report on primary type.
That's helpful. Thank you. I've got 3 further speakers, and then I'll draw the item to a close. So in order of who I saw, Cllr Kennedy, Cllr Adams, and then Cllr Samatar. Cllr Kennedy.
Thank you. This was very quickly on the discretionary funds and take-up of them, Chair. So as part of our response to the cost of living crisis, as a council, we're moving towards an income maximisation team. One of the things they will be doing is having a single web page and phone number for residents, staff, partner organisations that lets them know about discretionary funds, and one single application form. That's what we're aiming towards, to allow us to process applications for any discretionary funds. And rather than you applying and being told, no, you don't qualify for that, and then applying for a second one and a third one, you just say, I need help. This is my situation. We find one that might fit it for you.
I mean, I'm not over the amount of it, or even indeed the process, but it does strike me that entering this winter and cost of living, an observation that I think we've probably failed it as a council. If there's anything left in that discretionary fund at the end of the period, I think it's all incumbent on all of us to make sure, obviously, don't run it dry too soon, because obviously that would be people in need, but to make sure it definitely does get out there as a sort of priority. That's a comment. Cllr Adams.
Thank you, Chair. Thank you for the report. You know, in the report, it said that the City of London has a safeguarding adult committee. Do we have a similar committee in Hackney? That's my first one. Do we have a similar committee in Hackney? And my second question is, or clarification, or whatever, is that one of your achievements is that you commissioned a safeguarding adult review, a mandatory one, and there's a discretionary one as well. So why are you doing this discretionary one as well? And finally, you talked about intergenerational abuse during the COVID lockdown. How did you manage to deal with that?
First of all, I should have maybe explained the City of London subcommittee, because we're a joint board across Hackney and the city, and the Hackney population issues and preoccupations dominate. The City in London has its own special little committee to make sure we address specific issues that are unique to the city, because the city profile is very different to probably any other London borough, and so that's why we have a City of London subcommittee. I don't think we need one for Hackney, because actually the Hackney issues dominate the boards and the subgroups by definition, because of the volume of work and the nature of the issues that we have. So hopefully that explains why we have a City of London subcommittee. In terms of the difference between discretionary and mandatory reviews, this is a part of the Care Act definition. We can undertake a safeguarding adult review about anything that we choose to do so, and that is discretionary, but there are mandatory ones that when a situation meets the specific criteria. I don't chair the Safeguarding Adult Review Group. It's chaired by a colleague, and there's members of partners in that subgroup, and I think it would be fair to say, because although I haven't been part of the discussions, the recommendations are brought to the board, is that the issues that, or the cases that are taken to Safeguarding Adult Review are because partners feel that there is significant learning. So one of the criteria is it's got to be multi-agency, and there has to be learning that can be identified for a discretionary review. So the review process looks at the circumstances regarding a specific case. what went well, what hasn't gone so well, and what could have maybe been learned from that in order to make changes to prevent future recurrence. So the themes that are mentioned are issues that arose from those reviews, and there are recommendations that are then taken forward by the relevant agencies. As I said earlier about the event that we had during the year to revisit the review, the MS-SARS, the homelessness review, it's really important, I think, to go back and see that it takes time, that the recommendations and the response to those recommendations actually achieves the improvement and outcomes and improvements in multi-agency working that is assumed or expected out of that, and that's one of the things that we've started doing more routinely. So when we have the themes that are identified in the 3 reviews that are being published this year, and I think one of them is due to be published later on this month, it will come with an action plan of improvements that partners will need to take, and then my expectation is we'll come back, well, it gets monitored and the actions are expected to take however long they take, but then we'll come back and look at, has that actually achieved the shift and change that we're expecting? So one of the actions is around Think Family approaches. We are in a situation where adults and children's services often run on parallel tracks, and the Think Family approach is to encourage all practitioners to think about all family members. Seeing whether that has had an impact will take some time in terms of achieving the sort of shift in practice that we want to see achieved. In this particular case, there wasn't particularly good communication between children and adult services about different aspects of what was going on in that situation. I hope that answers the question.
And lastly, Councillor Samatar.
Thank you, Chair. And just echo on the thanks for the report is really detailed, and I was just going through some bits of it now. My question is a follow-up of the question that Councillor Baffour asked earlier with regards to languages and quote-unquote reaching hard-to-reach communities. I wanted to ask how this relates to people who identify as refugees and migrants who might not necessarily feel like they have access to some of the things that are available as part of the support within the mental health services, and especially right now with the cost of living crisis and everything that's happening in relation to what we discussed. How would, and I'm aware that this is being recorded in case somebody's listening and wondering how they can, if that relates to them, if you can please go over that a little bit.
Maybe if I can start and then colleagues can engage. I think it's a really challenging question in terms of ensuring that everyone who is in the borough is able to access the services that they need to access, and that includes safeguarding services and safeguarding issues. And particularly if you are coming from a situation where you're maybe not trusting or have not had a good experience of institutions and services, you might be reluctant to approach them. I'll answer the question in terms of what we've been trying to do on a longer term basis, and then perhaps colleagues can answer the more sort of specific operational challenge. On a longer term basis, what we've tried to do with the Safeguarding Adults Board in terms of promoting understanding, knowledge and awareness to all the communities and residents in the borough is support a community champions approach, which we've had, I think, 3 programs of and haven't been able to do during COVID, but have commissioned again this year, which is to support and train up peer educators, peer colleagues from the voluntary sector who are equipped to talk to through residents to resident groups and community groups about safeguarding and enable and raise awareness of and enable people to access services. So at a kind of longer term level, trying to improve the way in which the community groups can raise, can support residents to raise safeguarding concerns is something that's been on the agenda for a long time, and we've continued to try and promote. It doesn't address the specific issues, and I was going to say that some of that work, because I've been part of it, has been with community organisations working specifically with refugees and migrants, and that's been really important to me, that there's that reach through community organisations and services. But I wonder if a colleague would be able to respond specifically in terms of the safeguarding services.
I'll try to respond to that. So in terms of a safeguarding service, we have what is our statutory duty to respond, so those who have care and support needs. But I think irrespective of that, the expectation is if anyone contacts the Safeguarding Adult Service or anyone within adult social care, and they have concerns about someone who is a refugee or migrant or who has no recourse to public funds, my expectation is actually we always provide information and advice. We help to signpost and we help to make sure people are safe. Ultimately, it's about being flexible in our service and in our service provision to make sure that people aren't left destitute or in need, and that we work as a partnership to support individuals. We have a range of places that we do that. We've got high-risk panels, we've got the Housing, Health and Homeless panel, and there's just a range of places where we talk about individuals who, as I mentioned, might not have recourse to public funds, but where together we think about what the options might be to support them.
Just let me thinking, just to be clear, so if somebody has no recourse to public funds, I mean, your duty as sort of a safeguarding board still encompasses them, but the practical issue may be that the state levers, the different multi-agencies, might not be able to provide the support, is the conundrum.
So within adult social care, we would assess someone under human rights assessment to determine if we have a statutory duty to support them under the Care Act. If we don't, again, it doesn't mean we leave people. We try to look at what support might be available, about linking them into different networks, about trying to support them in to legal advice, for example. So it's very much about we don't leave people in crisis. We are absolutely there trying to support and make sure that someone is leading on making sure that they're safe and well.
Thank you very much. I'm going to draw it to a close. I think that was fascinating, and thank you both to the presenter and to members for asking their pertinent questions. So thank you very much. Please, those who were there for that item, please don't feel the need to stay for the rest of the meeting. And thank you very much for your attendance. I'm now going to move on to item 2 on the agenda, which is the Healthwatch Hackney Annual Report 21-22. I'm grateful for the Deputy Director of Operations, Catherine Perez-Phillips, for joining us. Thank you. Just by way of overview, we understand that Healthwatch is currently going through a sort of a transition period in terms of recruiting both a new chair and chief exec, as I understand it. So we understand this sort of this is set against that background. We thank you for getting out the report, notwithstanding those. And also, not all, say, members who were new members might appreciate that some of the work that is flagged in the report on page 14 about the investigatory reports you did, say, in terms of GPs, in terms of requiring photo ID that was brought to us, and we then raised with the commissioners, and matters like that has been very helpful to us. So with that overview, Catherine, if you want to give us maybe a short presentation, and then I'll throw it open for some questions.
Thank you, Ben. Yes, I've got a presentation, so let me just see if I can present that now. Hold on. And right, okay, so hopefully you can all see that. So yes, thank you for inviting me to come along and talk about our annual report, which is for the period from April 21 to March 2022. So I'm going to talk you through some highlights. So last year we got lots of feedback. So we got feedback from 250 people. So that's about 40 a week. And with that feedback, we code all that feedback in relation to the area of care it relates to and whether it's positive or negative. And we do that with the aid of local people who take part in our people's feedback panel meetings. And that ensures that we're as objective as possible in relation to that process. We published 5 reports, and I'll talk a bit more about those a bit later. And as Ben mentioned, the one into GP registration was one that was particularly impactful. And we have 20 volunteers, and they've been absolutely essential to enabling us to do the work that we do. So how do people feel about services in general? Satisfaction is 61% positive, which was a bit better than last year. We find that communication gets flagged as an issue. We hear that reception and clinical staff could maybe be more informative when booking appointments or maybe when attending appointments. And some people who have cancelled appointments, they haven't always had letters or updates. In relation to general quality and empathy, satisfaction is the same as last year at about 70%. So we do feel that the vast majority of people who received treatment and care get good quality treatment, and that staff are really working hard and are very committed. Access to services people's satisfaction is only 29%, and the ability to book an appointment remains a sort of continuing sort of negative issue that we hear a lot about, particularly in relation to routine appointments. General practice, the feedback there is 59% positive, an improvement on last year. People tell us that while they remote consultations are sometimes quite effective if they're time poor and so on, many people tell us that they do prefer to see someone face to face, particularly if there's a diagnosis or referral needed. We haven't got that much feedback from Homerton Hospital, and this is something that this year we're hoping to do better at. We weren't able to spend time at Homerton Hospital last year because of the pandemic. This year we've returned to going into Homerton to collect feedback from people. But yes, that there is an acknowledgement that staff are working very hard, and that although we have had some complaints about waiting times, yeah, people do sort of feel maybe there's a bit of a lack of staff there. So the Integrated Care Partnership, that's the umbrella term for the group of organisations that work together to deliver local health and care services. We have a engagement and co-production manager who works across these services with our public representatives, and she's done a great job in increasing the number of public representatives that we have from 8 to, I think we've now got around 24, and also expanding the backgrounds and ages of the public reps. And some of the work, as an example of some of the work that they've been involved in, they did some work around the acute dementia unit, which recently relocated to East Ham. The public reps were very concerned that the increased travel distance for people from Hackney would have a negative impact, as they would find it both more difficult and expensive to visit. So they met with representatives from East London Foundation Trust, which provides the service, and they co-designed a travel policy so that there's now free transport via taxi to all friends and relatives at the acute unit. They also co-designed some communications, some posters and information leaflets to make sure that everybody knew about the offer, which has made, I think, a big difference. We're always on the lookout for new public representatives, so if anyone's here and wants to get involved, please do get in touch. We have a dedicated community voice project. This project brings people together to discuss health and care issues that matter to them. During prior to the pandemic, we would have face-to-face activities, but that was sort of put on hold, and we had a number of virtual events. And as an example of that, we had, for example, a workshop around maternity, fertility, pregnancy, breastfeeding, and the COVID-19 vaccine. There was a lot of stories that were going around at the time on social media and so on, and so it was really important to do that work. We've also started running a community voice in health and care forum, and the forum meets quarterly, open to everybody. It provides a space for residents to come along and share their views, and we gather and collate feedback from a range of sources. We also are running we're also collating community voice health and in-care insight reports. These reports are based on the collation of all the feedback and data that we get. We then identify key trends and publish those reports and take recommendations to the key service providers. So, as Ben mentioned, last year we carried out a review. First of all, we carried out a review in June and July of. Oh, sorry, I'm talking about the wrong thing here. This is about the practice websites review, these slides, sorry. So yes, we carried out a detailed review of practice websites. And for example, one of the findings we found was that only 3 out of 38 practices had any information about the options to have an extended consultation. Only 8 provided any information about how to request an interpreter. So the practice review, the review of the websites was very positively received by practice managers. We've done a lot of the hard work for them in terms of going through their websites in a very detailed way and giving them detailed recommendations. And we found that following that, 24 practices out of the 38 implemented most or some of our recommendations. So that was a very pleasing piece of work. This is the piece of work that Ben mentioned. So we did a piece of work. We became aware that patients were being asked to provide proof of ID and proof of address. So in October, first of all, we did a report in April, and we found that 59% of residents were being asked for ID and 69% for proof of address. The CCG wrote to all the practices telling them that there was no contractual obligation to do this, and they should not ask for proof of address or for proof of ID. So we repeated the report, the research, and there was a considerable improvement. So in that report, we found that 18% of practices wanted proof of ID, and 26% wanted proof of address. So we are going to be repeating the report, the research next month, and we hope that at that point, none of the practices in Hackney will be asking for proof of ID or proof of address.
Catherine, can I just check, how many more slides have you got?
I've got, I think I've got about 3 or 4.
I tell you what, because I'm just looking at the clock here. Can you present on neighbourhoods? Can you present on neighbourhoods, because I want to hear it,
yes.
And also I've got a question on this.
Okay, so
Then can you leave it at neighbourhoods, and I'm going to open it up. Okay.
Yes, of course. Yes. Yes. So we've got a dedicated member of staff who works on resident engagement in neighbourhoods. So there's 8 neighbourhoods in Hackney, city in Hackney rather. So the neighbourhood resident involvement group has been closely involved in working on some aspects of work in neighbourhoods. So one of the things they've been involved in is working on what's called anticipatory care, which is a care pathway for people age 65 plus who've got long-term health conditions. And it's about people who maybe have some frailty and doing work to prevent them from getting worse, I suppose. So they engaged with 12 residents who could be eligible for this anticipatory care pathway to support the assessment and care and support plan. These residents also advised on the skills and training required of the care coordinator, who is responsible for engaging with the residents, and a working group is now taking place to do with that. We also did some work around communicating about neighbourhoods to residents, because a lot of people, well, probably, you know, it's a process, but they're not aware of the neighbourhoods, and started doing more outreach. So I'll stop sharing now.
Thanks, Catherine. That's very helpful. Just before I sort of throw it open to members, to the extent that you're able, are you able to give us a timetable on recruitment of new chief exec?
I'm not able to give you an update on that, I'm afraid. I think that yes, it's a matter for our chair, really. We have interim chair Lloyd French.
Okay, thank you. And Councillor Baffour?
Thank you, Ben. I just want to find out about the waiting time and the influence from the GP on the NHS, because for about within a year now, I've experienced kind of postponing of a few people that I know their appointment, and eventually they have to travel outside the country. But the third person was a heart cardio issue, and she went, but apparently she passed away because it was so intense that she couldn't wait. The appointment was last August, and it was rescheduled for October, which she couldn't wait. And the problem was too much intense that she couldn't wait, and she went. 3 weeks later, she died of the cardio. So what influence? Because the GPs are more closer to the rest of the patients, and they know the intents of the problem. So what influence can they do in terms of like helping to prioritize issues that is emergency, so that to speed up in terms of a waiting list and that sort of things.
Yes, I mean, it's obviously deeply concerning that somebody's had cancelled appointments and rescheduling of appointments, even to the point that someone sadly passed away before they could have that appointment. And this sort of feedback, you know, please do encourage people to use the feedback centre on the Healthwatch Hackney website so that we have the evidence, you know, to go to commissioners to tell them that these are the problems that people are experiencing.
Councillor Baffour, I mean, I think we regularly get updates from both the Homerton and Bart. I mean, waiting lists have been a very significant issue following on from COVID, and a lot of effort's been going on from the hospitals to try and bring them down. But I think they fully acknowledge the wholly undesirable situation that many people are currently facing because of it. It may be I can pick that up with you in terms of other information we've got about that.
I'll be more than happy to take it up seriously, yeah, because it's my greatest concern and sad times for this woman to pass out. Especially, they know the detriment and the seriousness of the case, but nobody did anything. Keep on postponing appointment till she lost her life, and it's very sad.
Yeah. No. Other members to ask? Councillor Adams.
Yeah, so I missed your question earlier on. I hope I'm not going to ask the same question. Right. There was a public meeting some time ago on St Leonard site. So I'm just wondering, because I've met a couple of people, because I live very close to the place. You know, I live in Oxford, so I live very close to the place. They've asked me what is actually going on there. And to be honest, I'm unable to tell them what's going on. So I'm just wondering whether if there's any, update on that meeting, what is going to happen next, because I knew the reason of that meeting was to carry the community along to have an input into what's going to happen to the site. So I'm just wondering whether we've progressed it any further than that. Thank you.
Catherine, I mean, I'll quickly comment in a minute, but Catherine, have you got any observations on the Homerton or update?
In relation, any observations in relation to the waiting list that the Homerton's experiencing?
In relation to the St Leonard site.
The St Leonard site. Sorry, I didn't hear you properly. Yes, I mean, we do plan to, it is part of the Healthwatch strategy for the coming 3 years. And I understand that our board wishes to, yes, have that as part of our strategy, and that we aim to certainly do some interim view visits to talk to patients and talk to staff. And as part of that work, we will talk to them about their views about any redevelopment.
Thank you. I mean, Councillor Adams, I mean, obviously, I think there was, obviously, there's also the Whips Cross site as well, but even with that, which is been something that's much more further down the planning stage, I think there have been concerns mooted about whether the government is meeting its commitment to even fund that, and that was one of its priority pathfinder sort of policies. So it may well be, I know, and it may well be that the Homerton have to get some sort of financial agreement before they can even sort of take that forward anymore. At the moment, they haven't got that, but I'm slightly speculating.
The community, they're kind of worried that they don't want the place to be sold off for, to build a block of flats or something like that. I think that's why people are really concerned about how it's progressing, whether it's kind of fell by the wayside, that, maybe we're not getting anywhere with it. So that's...
Jonathan indicated to me there might be a further meeting in November.
But Louise actually is coming down.
So what we've got the new chief exec of the Homerton coming here in November. So no doubt she'll be able to give us an update on what is going on with that, and then we can pick it up with her. I am going to draw this item to a close. Catherine, thank you for coming for your presentation. Thank you also for the report flagging in the introduction about dentistry, which is something we're hearing on from numerous sources and something we will pick up. And can you, when you revisit the photo ID point, which I've understood you are looking at, if you can let us know the outcome of that, because that may be something we then pick up with Richard Bull, commissioning side, if there are still any surgeries that still are asking for photo ID. So if you can let us have the outcome, that would be very helpful. But thank you very much. With that, I will. I see Laura Sharp hand up. So Laura, quickly, and then I'll bring it to a close.
Oh, it's that one. Thank you. Not the green one. Just to flag to you, we ran some training recently for all practices on registration and the law, and we particularly targeted, there were, I think, 8 or 9 practices that had been previously identified by Healthwatch as not quite doing things the way we might all want them to do, and we targeted all of those 8 or 9, I can't remember the exact number, and they all came to the training. So I'm hoping that we are whittling away at that and people are having a smoother registration experience.
That's good to hear. That's great. It's good to hear, and it's a good piece of work, as you say, where Healthwatch has had a tangible and evidential impact through the work you've done. So thank you. Thank you, Catherine, for coming. So I'm now going to go on to our third substantive item, which is the new integrated mental health network. In essence, we get the councillors going out to tender for this network. We're joined by Jennifer Milmore, who's a public health specialist for the council, and also Dr. Husbands. And I understand we're going to get a short presentation. Just to let everyone have the contextual situation here, we've got Vanessa Morris, who is, I understand, the director or chief exec of of mine as the current contract, and also Devorah Wilson, who's no stranger to Hackney, who's, I understand, is on the board of mine. They are the current provider, and just so there's clarity here, may well, I don't know, be seeking for the contract once it is retendered. So that's the landscape. Over, please, to Jennifer or Sandra. I think I did initially say when I was speaking with Jarlath last week, it would be helpful for maybe new members if maybe just a sort of 2-minute overview about the different mental health provision in the borough, from maybe more serious higher end East London Foundation Trust through to IAPT, and where where this commission piece fits in to the overall landscape. So if you could maybe just start off with a brief introduction on that, and then go on to the new tender, and just so hopefully you can address the questions, staple questions on the new tender. Is there a budget reduction on the tender going out, and how different will it be from the previous tender in terms of the framing of the contract? But over to either Jennifer or Sandra, please.
Thank you, Councillor Hayhurst. I'll start with just a very quick introduction, and then Jennifer's going to cover all the rest, including answering the questions that you set out last week, but that didn't make it into the presentation, which had already been submitted. So the big question is there won't be a budget reduction, and then the bigger bigger question which hasn't been asked is what's the longer term plan? And the longer term plan, which isn't included in this presentation, but explains why in this next invitation to tender we're looking for a shorter than usual contract term, is because we want to work with adult social care in particular, and also NHS colleagues on developing a more joined up, properly integrated mental health offer, which would include working more closely with ALFT and the elements of community provision and primary care. So I'm going to pass over to Jennifer, and I'll be here obviously for questions at the end.
Thanks, Sandra. And yeah, so just in case anyone's missed this, we are recommissioning the service at the moment, and it's currently out to tender. So this follows a quite extensive period of consultation and design, which has informed the current spec. And the tender will close at the end of October, after which a panel will review the applications, and hopefully the new provider will be approved at HPB in January, followed by a mobilisation period, and the new service will start.
Jennifer, we've got quite a few members, so acronyms, HBB. Can we go? I know I fall into it. If you can just set out what that is.
Yeah, the Health Protection Board. Sorry, it will hopefully get approved there in January.
Sorry, that's the Hackney Procurement Board. We've got too many acronyms.
Sorry, too many for me. And then there'll be a mobilisation period until the new service starts 1st of July next year. So on the next slide, hopefully this will cover your question around where it sits in the wider mental health landscape in Hackney. And so the new service will very much target people with complex needs, residents with complex needs. And they're people who have quite serious mental health problems, but also where these are intertwined with other complexities. This could be anything from substance misuse, housing difficulties, physical health problems, experience of domestic advice, experience of discrimination, digital exclusion, debt isolation, and where those problems intertwine mental health, it makes it very difficult to just address someone's mental health. And really the only way to support these kind of residents are to provide a holistic response, which addresses all of their needs. To support their mental health, and as I said, they still do have quite serious mental health problems. So as such, they sit below ALF. So ALF very much provide the mental health that's at the top of the pyramid, which is for people with very serious mental health problems, and those in crisis or very high risk of crisis. And the thresholds for that are really actually quite high. And then, so as I said, the wellbeing network will fall underneath that. And then a lot of you are probably aware of IAPT, which is, appreciate, another acronym. So that's increasing access to psychological therapies, I think also known as talk changes locally. And they provide talking therapies to people who have mild to moderate mental ill health. And as such, they're not so suited to providing support, the complex needs support that I just described, because it doesn't address all of the wider issues. And then there is also another layer beneath that, which is sort of around the more preventative early intervention, where there are quite a lot of resources available, both nationally and locally. And like I said, although the key focus of the new service is on that cohort of people with complex needs, there is also a requirement to help to support using the infrastructure of the service, what's already available there, but also increase the clarity of the offer, because while there is quite a bit, it's not always readily available and presented in a very clear way. So the service will be helping with that as well. And I have to acknowledge, I appreciate this diagram on your slide is very simplistic. And for example, it doesn't include the role of the VCS or of GPs or other services. And we know that it's just to give a sort of broad understanding of where it sits. So I hope that's okay and understood. And just to note, one of the main reasons for this current focus on people with complex needs is very much because through the consultation that we did, it was really clear that there is a high need in this area, but actually this need has massively increased in response to COVID, and it's expected to be a big problem for the next few years. So while our longer term is to also move public health funding more towards a sort of more preventative approach, at the moment, this is really a very important area, and taking funding away from this group of residents at the moment would potentially create quite a big risk, because they are also relatively high risk of crisis and unfortunately sometimes suicide. So it's a very important cohort to protect, and also it is still prevention. Like I say, we are preventing those more serious issues. And a further point that, by almost as a sort of the description I gave you of complex needs, are often also people who experience some of the greatest health inequality. So it is actually also a good strategy for helping to reduce health inequalities. So just to backtrack slightly and just on the next slide give you a little bit more context on the current service and what it provides, just very briefly. So I think I mentioned it's known publicly as the Wellbeing Network. This may change with the new service, and it was first commissioned in 2015, and it has developed in quite a few ways since then. It supports about 1,500 to 2,000 active clients, and in terms of the support it provides, it's quite a mixture, and it's personal to each client, and it varies from therapeutic interventions to activities to learning, as well as, really importantly, that one-to-one coordination to make sure that all their needs are being met as well as possible. Most of the referrals that come into the service come from self-referrals, but the other services such as GPs can refer in. And I don't know, I know quite a few people here were probably not around at the time, but there was, I'm aware, before my time, and it should be said before the current management's time, there was a review into the service, which did make quite a wide range of recommendations for improvement. And those have now all been actioned in the current service, as well as even more so in the new service. And actually, it was quite nice doing the stakeholder engagement, and we had quite a few comments around how since the new management have taken over, and even more since that report, that actually there have been positive improvements in the service since before. For example, in terms of how joined up it is and how responsive it is to other local services. And so in terms of the new service, on the next slide, we've made sure to keep some of the things that, again, through the stakeholder engagement, were made really clear to us that we're valued in the current service and we're really important. So one of these things is around the flexibility of the offer. So as I said, it very much varies for each individual service user. That the offer is always tailored to them, and there's no one size fits all. The number of therapies that can be offered are much wider than IAP, for example, and also include group therapies, but also the non-therapeutic interventions. There's also a very wide range of those to suit different needs and different requirements of this client. So, for example, we know that older men as a group don't tend to go for therapeutic interventions, and so actually by offering this wider range of options, we are able to better support that group and attract them to mental health support. And sort of related to that, again, it's very holistic, person-centered approach. We're definitely keeping that with a new service, and making sure that those underlying issues are addressed. And this also, again, relates to another thing that the current service does, and we really want to keep, which is around keeping the focus on recovery and moving towards independence from the service. So there's quite a lot of wellbeing interventions, which are great and definitely result in positive outcomes for individuals, but they can fade once attendance at those interventions end. So the purpose of the service is actually to help support clients to get to the point where they can cope independently from services by giving them the skills, knowledge, techniques, helping them to build social connections, and other similar things that help them to do so. It's also a very culturally and community specific offer in terms of there are a number of providers that mentioned in the previous slide who are based within the community, and therefore this allows the service to have quite a number of front doors, but also to provide culturally and community specific services depending on our different residents' needs. And while this is something we I said, the current service does. We actually hope to kind of improve it even further in the current service to make sure it is as representative as our population as it can be. And also, finally, it's provides an alternative to the NHS. So while NHS services are really important and really good in Hackney and the city, we do know that not all residents want to access NHS services, don't trust them or feel comfortable attending. And therefore, this does provide an alternative option for those residents. And again, all of the factors listed on the slide that we're keeping in the new service are all key parts of ensuring that we're addressing the health inequalities and supporting those residents who are affected by that. And then perhaps what you're more interested in the new service are the next slide. We have some of the key changes that are in the new service. So as I've already alluded to and discussed quite a bit, we are moving very much.
Stop you there. Is this the last slide?
Yes.
Yeah, fine. Okay. I want to bring members in for questions. So can I just ask you just to very briefly summarise that sort of in 30 seconds or so, and then I'll open up for questions.
Yeah, I'll do my best. So very much moving towards a focus on complex needs. I think I mentioned earlier that move towards also having the preventative open access part of the service. Much more focus on partnership working. One of the sort of really good examples around that is in terms of the IAPT integration. So actually people can get their one-to-one therapy, talking therapies from IAPT while still getting the support from the network, meaning that one-to-one expensive element is essentially provided still by IAPT as and when the people are ready. It's going to be much more integrated and flexible to adapt to changing needs of the population. Making sure that given it is a very specific offer, making sure that's even clearer to the stakeholders that we're working with, and also really strong emphasis on continuing improvement and developing. Continuous improvement and developing. So making sure that we're really monitoring what's working well and what maybe could be improved, and making sure that the service is really evidence-based. And this is supported by a flexible funding model we've included, which will allow the service to adapt and move to its resources to support this.
Thanks, Jennifer. So just before I open it up, I mean, I understand the move and the need at the more complex end, and that's certainly something this committee's heard about that need historically. But as I'm understanding this is quite a significant redesign in the sense that the previous wellbeing network, and correct me if I'm wrong, and I don't want to be too crude about this, but in a way sat next door to IAPT, or possibly even below it at a lower level of need. But one of its great strengths was the cultural diversity of the number of different groups that it reached out to. So who's filling that? How is that gap being filled or met? It's not being recommissioned in the same way. I mean, if it's becoming a much more complex need, and I understand the need of that, how are we providing for the different cultural specific groups that it's currently providing for?
So the new service will still provide support for those groups, and as I said, hopefully also be a bit more, even more representative of the population. The service actually it's never been the same as IAPT. I wouldn't say it provided that below IAPT intervention. It used to have a number of pathways in the service, some of which were for people with mild to moderate mental health support, but as the IAPT is available for those people, and actually in the current service, because of the changing needs of the population, as I said, it's sort of evolved since 2015 on its first mission, and actually now already we have allowed them to start focusing on people with complex needs, because that is really where the demand is, and also where there aren't services elsewhere. So IAPT can pick up that lower level, and IAPT also do have quite a culturally competent offer. They do have a number of different providers embedded within the community as well. And then also there's an element of which, we know that the voluntary sector do a brilliant job of supporting mental health as well. And in terms of the sort of more complex and higher level support we're asking to provide, it is much more costly, and it is something that really benefits from being funded. Whereas sort of some of the more community-based interventions, the voluntary sector is probably better placed to provide, even if there is perhaps a lot of there is more emphasis on them to provide that then, because there isn't as much mental health funding in general as across the country as would be ideal.
I've got two people who want to come in, but I just want to sort of just try and get to the bottom of this so I understand it. I've sat through 3 iterations now over the last 10 years of this going out to tender and procurement, and I remember quite strongly at a period where essentially the likes of Durham were not being funded, and then a lot of GP feedback about consequences of that, and how that was increasing workload upon GPs, and how there was a need for that provision. I mean, it is the position that whole host of community groups that were in the wellbeing network slide that we're still envisaging in some way or form contracting for them for the provision of services. Is that still part of the package?
Yes, absolutely. And sorry if that wasn't clear. That was supposed to be on my things we're keeping part of the slide. We can't guarantee who the providers will be because it is an open tender and it will be who bids. But in terms of the population supported, we are really looking for, as I said, all our population groups in Hackney to be supported. So those such as the Turkish population, which are big, we would expect there to be some specific support for them. Exactly how that looks will depend a bit on the providers and how they bid for it, and we've tried to leave a certain amount of flexibility in that, given that they are also experts in the area. But yes, that is something very much we look to continue in the new service.
Thank you, Cllr Turbet-Deloff. Oh, sorry, Son, do you want to come in?
Yeah, I just wanted to add in terms of whether we've now opened up another gap somewhere. We don't believe that we have. What we're doing is addressing a need that's revealed itself, particularly over the last couple of years. So there's still the lower level support, and we're also, as Jennifer described, sort of expanding the offer so that we also are doing more of the preventive work. And so there's still the support for people who have mental distress, but also more of the preventive work. So we should be trying to address all of the gaps in mental health and emotional well-being support. But also that's for this period. We will continue to work with the network and with partner providers and commissioners of mental health services to understand what the next iteration needs to be over the next couple of years.
Thank you very much for that clarification. Councillor Turbet-Deloff.
Thank you very much. I was a little unsure on how to formulate my question, but now it really has helped to hear the keyword, which is gaps in the services. I'm a mental health professional myself, worked in Hackney as well. I hadn't heard much about the network, wellbeing network before, and I'm hugely impressed by the level of services that it provides. What I would like to inquire or check, especially now with the new integrated mental health network, is at what point do patients are referred from either IAPs, who we understand previous to COVID had an estimated, according to reports, 750,000 people on a waiting list, which is a huge number across the country. But my question will be then, how do people that are not accessing IAPs because they are at that level of complexity access the new integrated mental health network? And the other question, which is within your new, sorry, I lost my page here, within your strengths, is there a possibility that there is a bit of a study on suicide rates and young people's accessing mental health specifically with the point that it is very well known that now young people are really lacking accessing mental health support in the NHS. Thank you. I hope I'm making sense. Your report really has sparked a lot of questions, positive ones and exciting too. Thank you.
Can I just ask for a clarification of the question before we answer it? So when you talk about young people, are you talking about under 18s or young adults?
Up to young adults, up to 25, yes, because one of a common theme that happens within, counseling and psychotherapy networks is that we hear that more and more young people are really needing to prove that they are in need of therapy, and they're not deemed as urgent in many cases or complex, to the point that we hear many young people are with chronic depression or even at suicidal stage, and they still take, there's a long time before they receive support. So I'm just thinking, would within these key changes be any, or is there any focus on young people and this kind of acute need for mental health support for them? Thank you.
I might start with that one then, as we've just been covering it. And yes, this is something that came up, and I didn't have time to cover everything. But yes, one of the sort of bits I was going to mention under partnerships was that there is an increased focus on that young adults group you mentioned. So the threshold for the service is still over 18, but we've put in a requirement to work with children and young people services to make sure that the service is linked in with the existing pathways for those services, to make sure that young people can access it and are aware of it. And there's also some very specific things we've included in the contract. For example, young people can be put on, kind of referred to the service before their 18th birthday, and this is to make sure that there's a smooth transition. So we know that sometimes there's the issue they can't be referred until they're 18, but then their services end, and then there's just a break while they're waiting. So this means that hopefully we can try and reduce the wait. We kind of found something that was probably just an oversight previously, but where care leavers are placed outside the borough up until their 25th birthday, where they are still connected to Hackney Council, even if they're not Hackney residents, they'll still be able to access the service. That was never an intention to exclude them, but they were unintentionally excluded. So there's quite a few points. Don't have really time to go through them all, and happy to chat with you outside. But yeah, there were quite a few points in the spec where we've sort of just tweaked it and made sure that there is that focus, as well as there being targets around. There's a few targets around, for example, young Black men as well, to make sure that they are represented in the service. And the first question in terms of how people are accessing IAPT. So I said we've had quite extensive conversations with IAPT, and actually the two services are going to be really well linked, and not just with IAPT but with other partners such as ELFT, and quite a long list actually. It's included in the spec. We're really asking the service, and this is part of the mobilisation, to set up trust referral processes, so that actually if someone does come into IAPT and go through sort of whatever process and fills in that information, provided there is consent, can be passed on to the network to try and smooth and streamline the process into that, and also making it part of the service's responsibility, which will be to promote itself to partners and to be really clear in terms of what the offer is. So IAPT colleagues should know who the network is for and when it's an appropriate referral. And so that should also make sure that we get the right referrals, if that makes sense, so that people aren't just being moved around and turned away at many points in the system. And I said, when appropriate, then there are options for that joined up support. So some of these lower level interventions that the network will be providing, which we're calling open access interventions, will be able to be accessed from the point someone joins the waiting list, also while someone's waiting for IAPT, so that they can get some support and as well. And obviously the links I described earlier, where people can be supported by both services where that's relevant. So hopefully the two should be really integrated, and the pathway between the two will be as smooth as we can make it. And so we've got that 6-month mobilisation time in which, as much as possible, those systems can be set up before the service starts running.
Thank you, Jennifer. Councillor Adebayo, you had your hand up before.
Yes, I think Jennifer just answered my question, because I wanted to ask about the cultural appropriate counseling service that is within the community, and she mentioned something about the services that actually encourage the black men to come forward. So I think that's answered my question. Thank you.
So, sorry, it's about the new service or the current service? Sorry.
You know, the new services that is coming, you know, that it provides opportunity for black men to be able to access counseling within the borough. And I just want to ask one more question. Do you know whether IAP is likely to increase their service, their numbers of sessions? I mean, the session number from 6 to maybe 8, because we did talk about the complexity of the issue that people are going through currently due to a lot of reasons. That includes the cost of living. So, and 6 sessions sometimes is not enough for people to engage in therapy.
Yeah, so I can't answer for IAP specifically, I'm afraid, because that's a different service, and we would need to check with colleagues on that one. I do know they are constantly looking at their service and increasing it, both in terms of their community offer, but also who they can provide to. So I know they've recently added so PTSD to the list of things which they can support with. In terms of the number of interventions, I'm not sure. I would have to double check. I think where there is more serious needs, sometimes people can access more, but again, it's not our service. I would need to check. That is one of the advantages of the network, which for people with more serious need, they are able to access more sessions, and as I said, kind of tailored to their needs on an individual basis. Unlike IAP, there's not a sort of one size, or not that IAP is like that, but it's even more flexible. So there's not a one size fits all. It's very much based on what each individual needs. And yes, as I said, the new service, that there are requirements to meet all the different ethnicity groups as far as we reasonably can within Hackney, including black men, and this will be something that we'll be monitoring the new service on. And as I said, there is that flexibility. So if for whatever reason that the new service isn't reaching groups such as that, which we want to make sure that they are, there is room for it to flex and change and adapt in order to better meet the needs of its residents. Similarly, if a new group emerges, which we're really concerned about, we've got the flexibility to adapt it to meet their needs too.
Thank you.
Thanks, Jennifer. I see Vanessa's raised a hand. I'll take this as the last contribution, and then I'll wrap up and close this item. Vanessa?
Thank you, Chair. No, it's just a point of clarification in relation to the IAPs and the number of sessions that might be available. And I answer as one of the IAP providers within the City and Hackney Wellbeing PTA, which is the Psychological Therapies Alliance, by which we deliver the IAP model. So the IAP model as it stands, and as it has been for the last 10 years, is highly prescriptive in its format. And so at step 3, which is the high intensity therapeutics, a more complex therapeutic offer, it is up to 16 weeks that is available. Mind nationally and locally have campaigned for that to be varied and for the range of provision to be widened, precisely because of the issues around complexity, people needing more flexibility, both in terms of how they are able to engage with therapy, but also the nature of the therapeutic model. But that looks like that's not nationally going to change and is currently quite clearly mandated. So that is also an argument for how wellbeing network providers are able to deliver a more flexible therapeutic model, which meets more closely the needs of the local community.
Thank you.
Thank you, Vanessa. I'm going to draw this item to a close now because of timing. I mean, I note the if I've got this right, the tender finishes in October. Sandra's indicated that it's a shorter period and there'll possibly be a bigger think going on as to how a new service could work. I mean, I think this committee would certainly be interested in possibly just understanding what the thought process is of a more redesigned service, and also maybe possibly at the point that someone's been appointed, just understanding perhaps in a little bit more detail about patient flow. I'm still not entirely clear in my own mind, saying that the number of people that are previously going through the wellbeing network and what sort of exactly what they were being offered and how that will then change with the shift to complex needs, and say are on average, is the system seeing 1,000 people less a year? And if so, if it is, who is meeting that need? Or yeah, I still just I think I appreciate we need to let the contract be awarded, but it may be that something we want to revisit either in a public meeting or a private briefing to fully understand that, just so we're fully sighted on it. But with that, I will draw it to a close. Thank you both very much for bringing it to us. With that, then, can I then turn to the fourth substantive item and the final one that we have on our agenda, which is Laura Sharp from the outgoing Chief Exec of the GP Confederation. Over the years, Laura has been incredibly insightful to us and a great contributor to the Hackney system, and we're grateful for that. Obviously, things are very much changing in primary care with the new integrated care system, with the new PCNs. And so I think to speak sort of from a Confed perspective about the new landscape, what are the advantages, what are the risks, what should we be looking out for, and your thoughts going forward. And we're also joined, I'm grateful, by Kirsten Brown, who is the City and Hackney lead as well in terms of primary care. Laura, over to you.
Thank you, Chair. Yeah, it feels very odd to be nearing the end of my career in Hackney after many a year, so quite sort of conflicted about that. But yes, at the end of October, I'll be leaving. So some personal thoughts really on where things are at and what might happen next. So I think my first major reflection for the group is that we don't quite know yet how the ICS is going to settle down. We're not entirely clear what will be happening at NEL level, what will be happening locally, how things will be decided as to which level they work at. The principle before NEL was set up was this concept of the 80-20 split, around 80% of the activity being local and to be determined locally, and 80% of the money to follow that. And I think that's quite an important principle to keep returning to as the NEL system settles in, because I'm not saying this is going to happen at NEL, but it is always a temptation to draw power, money, decisions to that higher level, when really they need to be out in the local. The first reflection would be keep 80-20 in your head over the next period and keep asking people whether that's actually coming to fruition or not. I think the second thing I'd say is that we're at, probably in my whole career, it'll be interesting to see what Kirsten thinks, I think probably the very hardest time for general practice that I have ever known, and there have been some hard times in the past. And it feels to me the sort of perfect storm of massive need, massive and serious clinical need from residents needing lots of high-level clinical attention. A workforce crisis. Only yesterday they were talking about that on the radio. I'll give you an example. Normally this time of year we run a salaried GP scheme and we get many, many more GPs applying for that scheme than we can take on. We usually have about 12 places. And all our local trainees who finished their training this summer, they're lobbying for places on that scheme to come and work in Hackney practices. We have one person on that scheme this year. Everybody, new trainees are saying, I'm taking a year out. I'm actually quite worried about joining the NHS right now with the level of pressure that staff are under. And I'm new. I'm going to take some time out. It's a bit too scary. And that really worries me. So we have to really care for our staff. We have to keep the ones who are already here and ensure they don't burn out. And I'm hearing lots of talk of burnout across all primary care staff. They're not alone in that, other staff. I know in terms of staff morale, practice staff are feeling really on the edge. And it's linked to things like the cost of living crisis. How do we support our patients? We see them in real crisis. What can we do? We feel quite powerless. So I think that there's a bit of a perfect storm there that, if we're not careful, will potentially overwhelm services. So doing everything we can to support staff and to support services and acknowledge when services are good, to keep people's morale up as much as possible. I think that's quite important. I'm worried about access. I'm not worried about, I mean, I know we need access. We absolutely need services to be accessible. And I know that the world of face-to-face versus phone versus digital is challenging for some patients. Some patients, it's amazing, it's just what they want. So we do have to keep the balance of access, but we have to also think that access is not the be-all and end-all. And I'm worried that it's going to be the only thing the government talk about. And the other things that make quality primary care will be lost in that conversation. So things like quality of care, ability to find space for people who really need, because of their complexity. We've just been hearing a lot about complexity of patients who need more time with GPs and with nurses in the practice. And therefore we have to protect for them, because they're the people who quite often are least able to demand that. And we have to rely on our practice staff to be able to protect time for them. So if access only turns into the people who shout loudest get it faster, then we're failing. We're failing our vulnerable patients, and we're failing our more complex patients. So yes, I think we should continue to talk access, but it's bigger than just, can I get an appointment tomorrow? It has to be a more rounded discussion. It has to be about quality. It has to be about continuity of care for the people who most need it. So it has to be a more rounded debate. And I'm worried about the future of the contracts that the Confederation runs and the practices deliver. Those contracts, we've got a 7-year contract to deliver those. Those contracts have been amazing. If you put that together with the high performance that practices have demonstrated on independent measures like QoF, the national measures, we can see that we manage long-term conditions really well, not just waiting for people to be ill with a long-term condition, getting to them first, calling them in for their diabetic review, managing hypertension, managing blood pressure is hypertension, managing chronic kidney disease, managing respiratory illness, calling people in. We're shifting to a preventative primary care service as opposed to a reactive. That is so valuable. It's taken 10 years. We must hang on to it, and we must protect it. It serves our most frail and vulnerable. It allows our practices to go and visit people who are housebound. I talked to my mum and dad about GPs going to visit housebound patients. It doesn't happen anywhere else in the country. It allows for that holistic assessment of a patient in their home. So, so valuable. So we have to hang on to that. That contract comes up, ends at the end of 2025. It's up for fundamental review at NEL level at the moment, many of those contract elements. We have to make sure we protect it. We've worked 10 years to fine tune it and tweak it and make it clinically sound and respectful of patient need. And we lose that at our peril. And that for me also takes us to this wider thing that we've managed to achieve in City and Hackney over the past 10, 20 years. We've got a system, a GP described it to me the other day as a balanced ecosystem. Because we have high-performing general practice and high-performing mental health services, high-performing community services, our hospital can work the way it wants. Our 111 numbers, that is people ringing 111 in the day, not when surgeries are closed, are the lowest in North East London. That's because people know they can ring their surgery. I know we will always hear of people who are struggling with that, but the data tells us that the vast majority of people can actually get to their surgery, get contact. They're not having to resort to 111. These are really important measures that tell us that we have a system that is broadly, yes, we can always improve, in balance, because we've invested in primary care, community services, mental health, and that allows our hospital to work well. The whole lot works as an ecosystem. We must hang on to that. So if I were to say, as we are in all this flux, what should we keep an eye on? It would be those things. There are some new things coming along as well. There's the Fuller report, which I don't know if the committee has looked at yet. This is a report written by a GP. It was originally a brief around how to help with access, but she went much further. She talked about continuity of care. She talked about quality. She talked about the desperate need to invest in clinical leadership. She talked about the neighbourhood concept that we already have and are working to in City and Hackney. She talked about complexity and fragmentation and inequalities and how all these things interplay. And she wrote a really good report. I do not want to see that report reduced to just GP access. So I would suggest that this committee could form a view around a role around testing the new NEL ICS and its delivery of the Fuller report in its entirety. And that would protect some of the things of value for us. And finally, clinical leadership. We have primary care networks, as you say, they are bedding down. They are still relatively new and utterly overwhelmed with the agenda they've been given. But those clinical directors are leaders of the future. Dr. Steph Coughlin is doing some very serious and good work in City and Hackney on clinical leaders now for the next tranche of leadership and the next generation. And having those people lead our system will keep us safe and give us quality. So investing in those leaders who actually see the patients day in, day out, who know how general practice works, who know how when you make a referral, it goes through the system and doesn't work for the patient. Making sure we keep their voice centre is really important. We've got people like Kirsten, that's amazing. We've got people like Mark Ricketts, it's really good. We must keep listening to what they tell us as jobbing practitioners and about what they tell us on behalf of their colleagues and their patients. So there are lots of pieces of the jigsaw, but we have to keep an eye on them, I think is my message. Ask those searching questions, demand that data that demonstrates that investment is happening in the 80-20 arena, and that will keep Hackney going for the next 10 years, I hope. I hope that's helpful.
Yeah, as always, incredibly helpful. I mean, you've touched upon one of sort of my concerns in terms of with the evolution of PCNs, the concern that at some stage some at the ICS level sort of say, well, there's some degree of duplication with the Confed, and we lose the great advantage that the Confed has provided. I mean, as you understand it, the other areas on the ICS patch, do they have a similar sort of setup to the Confed, or are we quite unique in that? I mean, I'm just trying to understand the overall landscape.
Yeah, there are federations in the other areas, but they don't do the scope of what we do. So they do support primary care networks and predominantly around things like extended access and the COVID vaccination programs. They don't hold the enormous contract that we hold for all these other preventative type services. That's worth 14, 15 million a year. So that So it's okay to have a Confed, but it has to have a role. We have a role. We must make sure that role isn't lost. We do a lot of work with Kirsten and Richard Bull about supporting practices to close for staff training, to have protected learning time, to have all sorts of infrastructure to support resilience. That doesn't really exist in the other areas. So their role is much, much smaller. Tower Hamlets, not so much, but all the others, I would say, much smaller role. And so the dilemma there about having a confederation and a set of PCNs and are you duplicating is less real. For us, the benefit the Confed brings, and I'm not saying it should stay with the Confed, but it certainly needs to be kept even across the 8 PCNs, is that borough-wide view and oversight and capacity, management capacity and skill that PCNs don't have, with some senior management expertise to drive agendas supported by the PCNs. So, you know, if the PCNs were to say at some point, we 8 want to do X, Y, and Z, they need a management infrastructure to help them do X, Y, and Z. And that needs creating for City and Hackney. It could be the Confederation. It could be that the PCNs have an office of the PCNs. It has a couple of members of staff, 2, 3, 4, 5, I'm not sure how many, but they're quite junior. So we do need to make sure that the PCNs have that serious management expertise to support them as well.
So really, I see Councillor Kennedy and Kirsten, I mean, in one sense, going forward to looking at the end of the Confed contract and knowing that PCNs is the latest kid on the block, as it were, in terms of where we are with sort of to sort of retain all that's good about the Hackney system. It's to really, we should be thinking now about how we can integrate and combine, and those two can work together, retaining what's been good about the Confed and that can support the PCNs, understanding that they have a role as well. I mean, I'm struggling with the fact that there's 8 individuals and the chair changes every. I mean, it just strikes me as if there's no cohesion. You know, if that still is the position when I heard about it 6 months ago. I mean, that you can't have an integrated system if that's what's going on. You need a leadership role that's pulling those PCNs together. But so sorry, that was a comment and observation. Councillor Kennedy.
And sorry, and just to say, we have a little steering group between the Confed and the PCNs that is looking at exactly this and how we could come together. So that work is beginning.
Great. Okay. Councillor Kennedy, and then I'll bring Kirsten.
Just very quickly to say thank you so much to Laura. Fabulous, wonderful, dedicated work. Extraordinary COVID stuff where you magicked up buildings that could be used to vaccinate people out of virtually nowhere, with extraordinary drive and resolve. Thank you so much for all your help across the system, and those final messages you left us with, absolutely brilliant. You know, keep 80-20 to the fore. You know, subsidiarity, and yeah, what a lovely challenge to always be asking, can you go further on the fuller report? So great messages, and thanks ever so much. I'm sure I will see you in other places. Thank you.
Kirsten. Mute Kirsten.
Sorry.
Hang on. Let's just have a look. No, we haven't got you on mute.
No, I'm not on mute.
Oh no.
Very, very faint.
Hang on.
You can't hear me at all.
Very faintly, we've got you. Hang on. We're just gonna play something. Go, Kirsten. Speak.
Can you hear me now?
Very faintly, but if you speak at that volume, we can hear you.
Well, I mean, Councillor Kennedy got in before me, really, was to say that, you know, Laura's contribution to general practice in City and Hackney has been immense. She's passionate about providing good care. She's knowledgeable, she's insightful, she's a pleasure to work with, and she has an incredible ability to get things done. I would say that would be my biggest thing about Laura. She just gets stuff done. On her points, I agree with all of them. We have a wonderful general practice in City and Hackney, but we need to make sure it stays in the centre of our system. We need a united voice, whatever that might be, whether that's the Confederation or the PCNs or a combination of both. We need a united voice for general practice, so we stay strong and we stay in the centre of our system. And I hope that we'll work towards that. And I think we are, and I hope we get there. So yeah, I hope you heard most of that.
We did. Thank you. I think we've. Yes, Councillor Adams.
The comment is about the surgeries. People in some areas where we have new development and everything, people are finding it very difficult to get access to GP, so they need to travel far. So that's a concern that we need to work on. And most of some surgeries, when they close, they don't replace them, so that is causing problems. So that's an area that we need to work on. If that makes sense.
In terms of sort of the surgeries closing and then amalgamating with another practice and the consequences. Yeah, I mean we've had that with Richard Bull sort of going through the sort of the criteria they go through, but it's certainly something we're aware of, particularly in areas such as Kings Park and where have you, where it's then leaving it without, say, a surgery provision.
I really think we need to try and be a bit more proactive in that, and not because we ended up reacting to situations. And one of the pieces of work that Kirsten and Richard has asked the Confederation to do in partnership with them is to look at what you would call in technical terms the resilience of every surgery. What are you struggling with? Are you struggling with buildings? Are you struggling with succession planning? Are your partners getting close to retirement? What's your plan for that? What are the things that are worrying you in the here, but in today, but also in the future, so that we can start to put some support around those surgeries, so we don't end up with suddenly taking almost by surprise by partners deciding to retire, or buildings not being fit for purpose or anything like that. So I'm hoping that we wouldn't end up in that situation again, because I don't think it's helpful for patients. You do need to be big enough as a surgery these days to offer the full range of care, but we have to balance that with geographical access, because we know that deprived populations find it hot. The greater the geography, the harder it is for people. So we really have to find that balance. And that's a really important piece of work that we're just beginning with, Richard. So I absolutely take your point. Yeah.
Thank you. I mean, bringing this item to a close, I need to echo what Kirsten and Councillor Kennedy have said. I mean, I think from my perspective, I know if Councillor Snell was here, he'd be echoing it as well. I mean, it's your ability. Obviously, new changes have sort of come through from above and from the Department of Health or the latest minister. But I think what you have constantly done over the years is you've managed to make that work for Hackney, whilst accepting that is what's coming down the line. But how do you pull the money in here? How you make it work? And as Kirsten says, and then you deliver from that, just playing the game within the new framework, but keeping a focus on what matters. And reminding us all of that. So we're incredibly grateful for you have been part of that very delicate ecosystem, and we're all aware that losing people like you, we need to, but with strong leadership sort of people still here as well. But thank you very much for your contributions here to this committee and to the health of Hackney. So thank you very much. Thank you. So thank you. With that then, can I And can I actually just flag, following on from that as a practical thing, Kirsten, I mean, that working group in terms of how the PCNs will work with the Confed going forward, and also being slightly marking our territory as to what we want as a Hackney system at the INL level, but what works best for us and what should be safeguarded. That may be something that this committee would want to pick up at the appropriate point, so we can make representations along with Councillor Kennedy and the Mayor and other people that some of these aspects should be safeguarded at the INL level. So it may be that at an appropriate point, maybe asking you to sort of bring a piece as to how the system can work between the Confed and the PCNs, and to retain that and advocate that really other places should be possibly doing that because of the evidence base that it does. You know, thinking about how we can then sell it to others and what, just an appropriate point. So that may be something for the future. Sure. So with that, then I will. I'll bring that to a close. Then just very quickly jotting through item 8 on the agenda is guidance for how health committees should operate. That's for noting. Minutes of the previous meeting, we've lost Cllr Oguzkanli, so I can't formally agree them, so we're not formally core it. We can do that next time. Work programs in the agenda, haven't been notified of any other business. With that, I'll close the meeting. Thank you very much, everyone. Thank you.